patient here shortly, but I appreciate it.
Thank you, Dr. Wilson.
I'm trying to take a picture right now.
Can you take a picture of you? You shut it down?
Yeah.
Can you put Nana slide back up just so he can be in behind them? What side is it?
Yeah. They got class.
I know. He's part of marketing. I'll hold this thing.
I like logged out.
Okay.
So I can't get it.
Oh, no, they have a class. They want to hurry up and come in.
Sorry.
Yeah, you go over there since it was your event.
Wait, and if y'all take one again.
No, it's fine. What happened? This is good or bad?
Yeah, this one is just the extra.
There's some to-go trains back there.
Dr. Huang?
I ain't joking.
Thank you for doing.
How's it going?
Doing well?
I am. I like your coat.
Thank you.
Dr. Huang.
Yes.
He's being so mean to you.
What's that?
Is this going to be an easy lecture or a bad lecture?
Good. Easy.
Easy?
Yeah, easy.
Dr. Huang?
So you're going to leave?
I'm ready.
Are you going to leave?
No, I mean, we got food. Is that okay?
Oh,
I'm never going to leave you.
okay.
Dr. Huang, are we going to take the whole time?
Hopefully not.
Easy one?
Come on. We need to
Easy
go
one?
ahead. Yeah, easy one. Yes. Not available. Hello? Hello? How are you today? Okay, listen to me. Can you hear me? Okay, can you hear me? Better? Good. So, a lot of things happening before the lecture, before our section. So we need to rush a little bit. So the first time, hello, listen to me. So the first part, we started a new process, okay? So basically you review some video and then allow to finish, complete the required. I say required. Sometimes I encourage you if you want to earn the bonus point, so you can complete. But actually we should say that's required, because that's very, very important. Allow you to understand better. So I will say, do your job to complete the bonus, the quiz. And so after today's lecture, so there is the vascular physiology post-lecture quiz. So we're open at 5. So, but the quiz will end on Friday morning. So just because we have a Huang on Friday afternoon. So everything, now we're going to complete the vascular physiology. So the first part, you learn a lot of things. So basically it's so-called biophysics. A lot of equation and law and everything. Basically, if you look at the take-home message for the lecture slides. So actually, there's so many things here. The most important thing you need to remember, understand, is number 4. So which is the blood pressure, blood flow. It's determined by the 2 factors. One is pressure gradient, and then allow the blood can keep moving forward when the blood leave the heart, and then it can keep moving forward from the great vessel and medium-sized vessel, artery and arterial, until to reach the capillary. So that pressure need to be rely on the pressure gradient to keep pushing the blood go to the capillary. So in order to do that, so the artery, actually the arterial wall, they have an electric fiber. So based on the electric recoil and push the blood to keep moving forward. Okay, that's very important thing. And the second thing is the so-called the vascular resistance. So the vascular resistance, even we talk about the first part we talk about blood flow, but actually it refers to the blood pressure as well. So that means everything applied to the blood flow. The by definition, blood flow is a period of time amount of blood flow passing a specific area. So, but that also refers to the blood pressure. So that means the resistance, vascular resistance, also applies to the blood pressure. So that means the second part, we are going to focus on how your blood vessel to use the resistance to change the radius in order to change the blood pressure. So that's what we also call a regulation of blood pressure. So today we'll talk about the peripheral circulation, and so everything will focus on how the blood vessel change the radius in order to overcome the pressure and generate the blood pressure, to regulate blood pressure, and what the mechanism, the intrinsic and the extrinsic mechanism. So how they change the radius in order to regulate the blood pressure. And the last part, we are talking about the regulation arterial blood pressure. So that means we talk about so-called, during your small group, you discuss like a baroreceptor reflex. What is a high pressure baroreceptor? What is a low pressure baroreceptor? And how that receptor respond and incorporate the autonomic system to regulate the whole body blood pressure stable. Okay, so move on here. The first slide you can see here. Recall what's a Poiseuille's law. Okay, so the law, the flow rate, the blood flow depends on several different factors. So most important, 3 important factors listed right here. One is called viscosity, and the vessel length, and the vessel radius. So usually in the blood, normally viscosity, it won't be a problem. because in the normal situation, your blood viscosity usually keep the same, very stable. Several conditions happen. For example, polysesthesia. So when we talk about the respiratory system, when you stay in high altitude for a long time and your red blood cell keep producing, and then will also increase the hemoglobin concentration. In that situation, they will become the polysesthemia. So in that situation, will change your viscosity. Or you have another situation called anemia, so they reduce our red blood cell. So probably the particular situation, you get the viscosity will change. So otherwise, in normal situation, the viscosity is not a problem. For the pressure, for the flow, it's not a problem. The most important thing is about the length and also radius. The length is very easy to understand. So we talk about the pulmonary circulation. So from the right ventricle, the blood pump out away from the right ventricle. The pressure almost about 25, right? The maximum about 25 millimeter mercury. But compared to the systematic circulation, the blood pump out from the left ventricle, the blood pressure will up to around 120. So it's a huge difference. Why is the difference? That's because the distance from the pulmonary circulation from the right ventricle to the lung, the distance is shorter than the left ventricle pump up the blood to your upper limb, lower limb, anywhere, even to the neck or head. So it's a long distance. So that's why the short distance, the resistance is getting smaller. So that's why here say the resistance is directly proportional to the vessel length. Longer, so that means the resistance bigger, larger. Okay. Think about the pulmonary circulation and the systematic circulation. Probably can easily understand. Okay. Then the last one is so-called the vascular radius. The radius to change the diameter. So that's the important factor. So already know based on the law. So you see the resistance is inversely proportional to the force power of the radius. So that means you reduce or increase half of the radius. So the flow rate or the resistance will going up or going down around 16 times. So that's a very important thing for the vascular radius. And also later when we talk about the blood pressure regulation and the local regulation, the blood pressure regulation, that's because your blood vessel can change the radius and allow to increase the resistance or decrease the resistance. How to do that? So basically, you learn about it, how we can constrict the vessel or dilate the vessel to increase the radius or reduce the radius and change the resistance to allow you to change the blood pressure. So even we talk about the blood flow, but actually in the arterial blood pressure is also mainly by the resistance. So that means the blood pressure is also, the radius, the change is also important to the blood pressure. Okay, it's the same thing. There's three different types of vessel. So you can see that in the normal artery in the center. But in the right side here, you can see the radius getting smaller. So the radius getting smaller, that means the resistance getting higher, right? Because the radius reduced is inversely proportional to the radius. The force power, okay? So the diameter reduced, radius reduced, and the resistance increased. So that's why the flow or pressure will getting higher, and then the flow getting slow. Compared to the other, so if you have a decreased larger radius, reduce the radius, so then you reduce the resistance. Now reduce the resistance, so basically it increase the blood flow and also reduce the blood pressure. So everything is regarding the change of the resistance. So, but your blood vessel can do this job. How can it do this? So the laser, now you see here, it basically is the profile of the blood vessel. So right here is the profile, and then enlarged to here. So in the inner surface, right here, the inner surface and the smooth muscle. That's right here, you can see that's in the endothelial cell. You learn this histology, so that's why you know the structure of the blood vessel wall. There's the endothelial cell and the smooth muscle cell. Important thing is several different molecules we call endothelium-dependent vasodilator. So this molecule, for example, the histamine, acetylcholine, or bradykinin, this molecule can trigger the endothelial cell to produce nitric oxide. And the nitric oxide is a very powerful vasodilator. So this molecule can diffuse into the smooth muscle, then it can reduce the smooth muscle contraction. How they do this, next slide will tell you. I believe that in your small group you discussed smooth muscle contraction, the mechanism. So one is important enzyme, we call the myosin light chain kinase, play important role to change or regulate the muscle contractions, especially in the smooth muscle. In addition to this molecule, but also some so-called myogenic factor. So here you can see that the shear stress. That means it's stretch, directly stretch endothelial cell. So this kind of mechanical stimulation, the stretch of endothelial cell, and this is the way also can trigger the endothelial cells to produce the nitric oxide. Again, the nitric oxide diffuses to the endothelial, to the smooth muscle cell, and to dilate smooth muscle cell, to reduce the contraction. So that's why they dilate the whole vessel lumen. So we call it vasodilation. So you have to remember the so-called vasodilator. So this kind of molecule, nitric oxide, prostacyclin, or AMP, atrial natriuretic peptide. This is the peptide secreted from the atrial wall to dilate the blood vessel. Another group we call vasoconstrictor muscle, constrictor molecule. So this group of molecule actually do the opposite activity. So that means they can contract the smooth muscle. So then when the smooth muscle can contract, actually they reduce the radius of the vessel. So this molecule, one thing, the first one we can see is endothelin. Endothelin here actually reduce from the endothelial cell and also diffuse to the smooth muscle. And this endothelin actually in the normal tissue, it doesn't exist. It's very rare. It only happens in this when the endothelial cell damaged. For example, like pulmonary hypertension. So it's damaged, and then the endothelial cell will secrete endothelin. Endothelin and then cause the smooth muscle contract, and then reduce the radius. So that means it indirectly caused the vasoconstriction. Another molecule like angiotensin II or vasopressin, also called ADH. So we will mention this molecule often today. And because angiotensin II actually is not really produced from the endothelial cell, because in the two organs are involved. One is kidney, one is the liver. And then at the end up, the product will be angiotensin II based on the enzyme, converting enzyme, and convert the angiotensin I to angiotensin II. So very similar like from the inactive form to the active form. So when they convert to the angiotensin II, and then it will diffuse to cause the smooth muscle contraction. Okay, then later we will talk about it because it's involved in the long-term blood pressure regulation, and they will secrete the renin from the kidney, and that the subsequent product. So ADH is the hormone, right? It is secreted from the posterior pituitary gland during the sympathetic stimulation, and the posterior lobe our pituitary gland will secrete ADH. So this ADH, they work on the vessel, also work on the kidney. So when we talk about renal physiology, we'll talk about ADH will reduce, increase water resorption in the kidney. But right here, right now, for the vascular regulation, we only mention that ADH work on the membrane, the vascular wall, and then trigger the smooth muscle constriction, reduce the radius. So overall here, you can see the two groups depends on how they work. So they can regulate it to increase the radius or decrease the radius. So when they then so that they can change the resistance and change the blood pressure. So allow your body to regulate how you can increase the blood pressure or decrease the blood pressure. So we talk about the nitric oxide. The nitric oxide is the molecule diffused from endothelial cell, and how nitric oxide is produced. So you can see here the endothelial cell. Based on the biochemistry, there are two types of enzyme. One we call inducible, one we call constitutively. So you can say the INOS or CNOS. Okay. For these two enzymes, and then I can work on the different substrate. For example, you have L-arginine, which is the nitric oxide, the precursor, or the cytokine. Or you can do in the shearing forces, which is stretch, or the other vasodilator we just mentioned earlier, so acetylcholine or bradykinin. So this kind of thing, they all produce nitric oxide, but based on they work on different type of the synthetic enzyme by INOS or by CNOS. So INOS it's a strong activity. It's higher, about 1,000 times than CNOS. But overall, when nitric oxide produced and then diffused to the smooth muscle cell, when they diffuse to smooth muscle cell and then trigger the granulin cyclase to trigger the nitric oxide, convert the guanosine triphosphate, and then they become the guanosine, the cyclic guanosine monophosphate. So this is the biochemistry. So basically, when they convert here, and then we'll reduce this myosin light chain phosphate. So we reduce this enzyme. So when they reduce the enzyme, actually they reduce the myosin and actin binding affinity. It's different from the skeletal muscle, right? The skeletal muscle, you learn the myosin heavy chain and can bind an ATP, and phosphorylation allow the myosin heavy head. Myosin head can have energy allowed to binding on the actin. But in the smooth muscle, they use the different mechanism, which is the myosin light chain kinase to produce the similar molecule allow the myosin can bind onto the actin. Okay, so the detail, we don't need to talk about it, the detail right here, but you need to know the nitric oxide actually reduce the activity of the myosin light chain phosphatase. So they reduce the smooth muscle contraction. So when they reduce muscle contraction, actually to increase the radius. So that's when they reduce the resistance. Okay, so far good? Okay. That's just a review. We'll talk about the vasodilator and the vasoconstrictor. So this right here, they may use a different mechanism, either using the guanine, the cyclic AMP. For example, like in the adenosine here, reduce the increase the cyclic AMP or cyclic guanosine monophosphate. So there's the biochemistry, the mechanism, they end up to allow you to know what will produce the nitric oxide. And then the nitric oxide, even they have through the different pathway, different mechanism, but the end product will be nitric oxide. When they become nitric oxide, it diffuses to the smooth muscle and then reduce myosin light chain kinase phosphatase, and then reduce the smooth muscle contraction. Is it too fast? No? Yes?
So how does myosin light chain phosphatase help to, like, is that enzyme involved in the facilitation of contraction? I thought it was the kinase.
No, because that enzyme is very important, allow the calcium to bind in, allow the myosin can bind onto the actin. So this enzyme is help doing this job. It's different from the skeletal muscle. The skeletal muscle is phosphorylation happen on the myosin directly. But in the smooth muscle, they have to using the myosin light chain kinase. This enzyme allow the calcium can binding on, allow the calcium, when the calcium present, allow the myosin can binding onto the actin, just because of different mechanism. Okay. So the bottom line here, you need to know the smooth muscle contraction using a different mechanism, and this nitric oxide to reduce the enzyme activity. So that's why they reduce the muscle contraction. So that's the basic concept. When you compare the smooth muscle, cardiac muscle, and the skeletal muscle, you need to know the different thing. Skeletal muscle and cardiac muscle use very similar mechanism, but smooth muscle doesn't. Okay? So vasoconstrictor, angiotensin II and the ADH. So they also bind on the receptor and then trigger the calcium release. And that also, in the smooth muscle, the myosin light chain phosphatase also involved in this mechanism. But it eventually, dilation or constriction is based on the concentration of the calcium. So you compare the different three types of muscle cells: skeletal muscle cell, cardiac muscle cell, smooth muscle cell. Maybe they use a very similar or different mechanism, but the only common thing they needed is calcium. If you have a calcium, you can have a muscle contraction. If you don't have calcium, you cannot contract. That's the bottom line. Okay? So now you know the vasodilator and vasoconstrictor. But in the local circulation, usually we have the so-called extrinsic mechanism and the intrinsic mechanism. Intrinsic, first of all, the intrinsic mechanism is one term we call hyperemia. So hyperemia, that means you suddenly increase the blood flow at that moment. So for example, like this case, the normal blood flow, and then during the ischemia, so no blood flow, right? And then suddenly the blood flow increase. So this we call hyperemia. But this situation we call it reactive, just because during the ischemia, and they will produce a lot of waste. For example, carbon dioxide, for example, proton, for example, another potassium ion. So in that situation, it just accumulated in the vessel. Then suddenly, if you remove, you provide oxygen or you have another procedure, then the blood flow will increase. So this we call hyperemia. It's a reactivity, suddenly increase the blood flow. Another situation, maybe during the active hyperemia, so that usually if the cell or tissue passing through the vessel passing through this organ, and then suddenly they have a very strong metabolism, so they need a lot of blood supply. For this situation, we call active hyperemia. So without produce anything waste, but just because the tissue or cell need blood. So very similar, like we learn from respiratory system, we call recruitment in the passive control, improvement or distension to increase the blood flow. When they need it, the blood flow and go there. So in that situation, we call active hyperemia. So the last thing here is the so-called myogenic regulation. So this is a very similar thing like we talk about the shear stretch. When the stretch on the vessel wall sense the different pressure, different volume of the blood, so they will change the radius. When I change the radius, the blood flow will increase or decrease. In that situation, we call myogenic. So in the future, from now, even to the renal system, we will mention a lot of things. For any baroreceptor, usually because they can sense the blood pressure. So that's why they change the stretch, they change the radius. So that information can send to the brain center and change the nerve regulation and do the following activity. So this is what we so-called intrinsic. When we do the local circulation, you will happen this mechanism. The other we so-called intrinsic. Intrinsic is to focus on the nerve innervation. We know how your blood vessel constrict. Sympathetic nerve fiber can contract, can cause constriction, the vasoconstriction. That's called the intrinsic mechanism. Or parasympathetic can do the vasodilation. So that's the parasympathetic innervation. By what? By neurotransmitter. Remember? The sympathetic nerve fiber will release neurotransmitter, which is norepinephrine, and binding onto the beta-1 receptor and cause vasoconstriction. So the parasympathetic fiber, they will secrete acetylcholine and binding onto muscarinic receptor, right? And then cause the vasodilation. So that's the example for the intrinsic mechanism. The last one, the hormone, humoral regulation, very simple, like ADH. The ADH secretion secreted from the posterior pituitary gland, and then it will work binding onto the vessel and then cause the vasoconstriction, right? So overall, the three different factors like include in the intrinsic mechanism. This is the summary. Okay, so you have an intrinsic mechanism on the left side and an intrinsic mechanism on the right side. The arrow, the color, is telling you the different vasoconstriction or vasodilation. So the green is the vasodilation and the red is the vasoconstriction. So in the intrinsic side, summarized, we just learned from the previous slide, we talked about hemorrhagia. It suddenly increased change the radius and then change the pressure and then change the blood flow. So right here you can see if you increase amount of pH or oxygen, that will cause vasodilation. And if you reduce the amount of oxygen or pH, if you increase the amount, that means produce a lot of waste, like carbon dioxide or potassium or different so-called vasodilator, and will cause the vasodilation. So the only thing you can see endothelium, so that we just mentioned, that only happen when vessel damaged. For example, in the hypertension, and then the endothelium will damage the endothelial cell, and the endothelium secreted, and then cause a vasoconstriction. And so the stretch, also called the vasoconstriction. Okay, but this is what we call the myogenic control. Myogenic control, okay. You remember this term, okay? And then the other side will intrinsic, based on the nerve innervation or hormone control. The nerve innervation or humoral control, okay? So we mentioned the sympathetic or parasympathetic. The sympathetic here, for the sympathetic fiber, because they have a different receptor subtype. For the vessel. For the vessel here, we talk about it for if the receptor is alpha subtype receptor, it happens in the kidney. So this will cause the vasoconstriction. But if the receptor is beta type, right here, and then it'll cause vasodilation. So the angiotensin 2 and ADH. So this is the molecule to create, because the kidney and the liver and eventually will produce the angiotensin 2, and then it's also a member of the vasoconstrictor. Okay, so overall, to give you some idea, so different molecule, different mechanism will cause the change of the radius. Why we do not change the radius? Because local circulation, they need to meet the change moment to moment. For example, now you sit on your chair and you stand up, so the pressure will change. So you need to change the blood, the vessel, the radius of the vessel, allow the blood to provide the blood to your whole body. So if you don't have sufficient blood go to your head, your brain, so when you stand up, probably you will fade. You're fading again and then sit down. So that's why the insufficient blood supply to your blood, to your brain. So in order to do this, so your local circulation have to meet your body need by changing intrinsic factor or extrinsic factor. They can work together, allow you to do the blood pressure regulation. Okay? Okay? Good. The take-home message here, think about it. So many things we will mention again in the second part. So in the second part here, we just focus on how blood pressure regulated, and what is the baroreceptor, and how you can deal with so-called syncope. So we will talk about it a little bit. So now the regulation of arterial blood pressure. So this is the summary here. So we can see the blood pressure. So blood pressure is referred to the mean arterial pressure. How do you calculate? Do you know how do you calculate mean arterial pressure? Okay, that's one thing. Okay, cardiac output multiply the total peripheral resistance. That's one formula. So the other formula we can directly calculate from the systolic pressure, right, and diastolic pressure, which we call the different, we call the pulse pressure. So we mention that again. So when the blood pressure usually refer to mean arterial pressure, that's the general the blood provide to your body, how sufficient you would, like we call the mean arterial blood pressure. So there are two factors to impact the blood pressure, which is cardiac output and vascular resistance. And the cardiac output also determined by the heart rate and the stroke volume. Right? You know that, right? So the stroke volume, basically here is a so-called conduction system, which is SA node, AV node, right, and the bundle hits. And the stroke volume here refers to the muscle contractility. So the three different factors, like afterload, contractility, and the preload, will determine what is the stroke volume, right? And then your contractility, the vascular resistance, it also depends on the how your vessel constricted or how your vessel dilated. So it will change the resistance. And there's a resistance if the total whole body, the resistance adding together, so we call them total peripheral resistance. Then you can use in one equation, like you have a cardiac output and multiply the total peripheral resistance. Then allow you to calculate the mean arterial pressure. So the mean arterial pressure, if the arterial pressure getting high, so that means you need to have a higher afterload. So that means, for example, the patient have hypertension. So the hypertension, so you'll see the blood pressure very high. So in order to pump the blood outside the heart, so then the heart need to overcome the very high pressure in the arterial, in the artery. So that's why you would also change afterload. That means you have high blood pressure, then you have a higher afterload. So the afterload and the pressure in your body system, there's a system to monitor the blood pressure. That's the so-called baroreceptor. The location will in the common cardiac artery. So one thing here we call cardiac sinus. In your slide here, talk about cardiac body or sinus. Okay, so you can download the updated version. So already in the Blackboard. So this is because cardiac body is a different thing. Cardiac body is the tissue which detect the carbon dioxide or oxygen. But the cardiac sinus here is the cardiac sinus baroreceptor. Actually, is part of in the vascular wall. It is a specialized structure, allow you to send the stretch based on the blood pressure. Then when it stretch, depends on the pressure, then they can send a signal to medulla. So right here, the medulla actually is the vasomotor center or cardiovascular center. Right in the center, they will do a different thing. For example, if the pressure too high, and then they will trigger the signal and reduce the resistance or increase the resistance in order to increase the pressure or decrease the pressure. And also, this center also will working onto the cardiac muscle cell to increase or decrease the contractility. How do they do this? Based on it's only sympathetic nerve fiber can control cardiac muscle cell, right? Am I right? Okay, that's a very important thing to do. Okay, you have to remember this. So the sympathetic fiber releases norepinephrine and binding onto the beta receptor and cause the muscle contraction. So increase the contractility. So one hypertension we can provide the drug, which is the reduce the blood pressure. What is that? We can use in a blocker to treat your patient with the hypertension. So we mentioned that earlier, right? So we call that the so-called beta blocker. So the beta blocker, the beta because the beta receptor for the sympathetic nerve fiber, and block the receptor, actually the binding, compete the binding site of the norepinephrine. So that's the drug produced for. So they compete the binding site. When they occupy the binding site, so the normal norepinephrine cannot bind onto the receptor anymore. So they will reduce the activity. So that's why they can reduce the contractility. So, and also this center will trigger to increase or reduce the venous return. So that's working onto the venous wall. Majority of the blood is stored in the venous system, right? About 60%. So whenever you need it, your sympathetic nerve fiber will trigger constrict, allow the blood go back to your heart. So that will increase the venous return. And the last thing, this center, of course, will regulate the heart rate. So overall, this center, when they regulate a different thing, and they regulate the cardiac output, and regulate the vascular resistance, then they can eventually regulate the venous control to make everything the circulation complete. Then you can have a good output and very good input, which is preload back to your heart. Remember, your heart only can pump out the blood, particular amount of blood when the heart receives from the inferior vena cava, basically in the right atrium. Okay? In addition to this, the center, for example, hypothalamus, they will, based on your emotion, based on your situation, and for example, you fear, or when if you're fearful, and when you have anxiety, and so that kind of thing, emotional, very down, and probably the sympathetic activity will increase. When they increase, it will increase the heart rate. So everything, not only your cardiovascular system, but also the nervous system, but also your central nervous system will participate, work together, have fun to regulate it, to change your blood pressure. So that's why your heart, you need to have some information go back and allow to have a very big picture and to regulate, meet your body need. So now, later here, we talk about the volume cardiac output. It's very similar. I think it's like review. So right here, you need to know what is cardiac output and what is formula allowed to see that. So usually when you look at the Wigger diagram, the normal heart rate, normal cardiac cycle. So you have to know what is end diastolic volume. So that means right after your isometric contraction, right? During the isometric contraction, so the maximum amount in your ventricle we call end diastolic volume. So that amount about 120, 130, normal amount. Then after the ejection, which is we call ventricular systole, after ejection, then after the isometric relaxation, then some blood will be left in the ventricle. Not totally amount of blood will pump out. Like a lung, where you breathe out, but still have some residual amount of volume left in your lung. So in your heart, the same thing. When they pump out the blood, but still have some amount of blood left in the ventricle. So the amount left in the left ventricle, we call them end systolic volume. And the difference between the two volumes, we call them stroke volume. So that means every cardiac cycle, every heartbeat, how much blood can be pumped out from your heart. Remember, in this case, 120 to 60, so around 60 milliliter blood will be pumped out. And from the left ventricle, so the same amount of blood will be pumped out from the right ventricle as well. But just because the pressure is different, they only deliver to the lung or deliver to the body part. So that's why I call the pressure different. But amount of blood will be the same. Okay? So several things here. You need to know the stroke volume, and the cardiac output will be stroke volume times heartbeat. Depends on how sufficient, how string the work you are doing, so they will change the heart rate. And do this, we mentioned the stroke volume sometimes will increase a lot, maybe from 60 to 120. So for example, when you do the exercise, and you need a lot of blood to provide the oxygen and provide the nutrient to the whole body. So that's why the stroke volume was very big. So that will be, it depends on your situation. So that actual blood will come from your venous reservoir. Remember, we say about 60% blood in the venous reservoir. When that blood, you need it, the sympathetic innervation will trigger the vessel constriction and push the blood, increase the venous return to your heart. Then you can have a stronger and bigger, a larger amount of stroke volume. One thing we call the ejection fraction, so they will be evaluate how good of the contractility of your ventricle. So that means if you only have, usually the efficiency around 50 to 60. So that means every time you pump out the 60%, 50% of blood, that means your heart, the contractility is good. But sometimes if you have a very low, for example, lower than 40%, so how do we calculate it? Basically, you using the difference, the stroke volume divided by the end diastolic volume. When you calculate them, and then probably you can see the number. So if the proportion, the percentage is lower than 40, so what is called the heart value, basically the heart value. And the heart value, and also that's a very reduced ejection friction. This number just allows you to see, okay, there's a fraction allow you to evaluate how good, how strong the contractility of your heart. There will be depends on different factor. Even you have a very normal ejection fraction, but somehow, for example, you have a patient have the pulmonary hypertension, so even the heart can pump out a lot of sufficient blood, but still because they have a hypertension. Then the ventricle will probably become the hypertrophy. Then the lung, the gas exchange is not sufficient. Even in the lung will have the water accumulated. So usually the patient, even they have a normal ejection fraction, but still the patient will feel very fatigued or even cannot breathe, something like side effect. That's just allowed to see, okay, that's a way, not only see the stroke volume, or you can use in the ejection fraction and to evaluate the function. Similar, like why you need to learn the EKG, because in front of EKG, you can have a better idea what happened to the heart. Is the problem in the atrium or the problem in the ventricle? Or what is happened because of conduction system, or because the problem happened in the contractile cells, which is cardiac muscle cell. Okay? So the stroke volume depends on 3 factors, which is mentioned here: preload, contractility, and afterload. So the preload actually is the volume. But by definition, the preload is because when the blood goes from the atrium to the ventricle, and the muscle stretch to the maximum, then that pressure we call preload. But that number we cannot really measure. The only thing we can measure is to measure how much blood in the ventricle. So that's why we use the end diastolic volume as the preload. Okay? So, and then the preload, if you have sufficient preload, and then you can pump sufficient blood out, so your cardiac output will keep normal. And the contractility, just because how good your heart can contract. So that the contractility also a very important factor. And afterload, we all know the afterload is the ventricle to overcome the pressure in the aorta or pulmonary tract, pulmonary artery. Allow to overcome the pressure, then the blood can push open the semilunar valve, allow the blood go into the great vessel. So the 3 factors will determine how is the stroke volume, and also indirectly impact your cardiac output. Yes?
Is the stroke volume in your pulmonary equal to the circulatory?
Stroke volume, yes. Yes. So we just take a question, is it the same amount of stroke volume from the right ventricle and the left ventricle? The answer is yes, they are correct, the same. The stroke volume, that's mean one cardiac cycle, one heartbeat, how much blood your heart can pump out. So the right and left are the same, identical amount of blood. Okay? So then the afterload, not only the pressure thing, but also sometimes depends on how healthy of the valve. For example, the valve may be damaged. So the damage also will impact on the afterload. The venous return here, we know the pressure gradient is very important. So if the atrium, if you can imagine if the atrial pressure is larger than venous pressure, your blood cannot go back to your right atrium. So your atrium pressure is getting low, then you can have a sufficient venous return. So for example, if you have a problem on your right atrium, then the pressure is higher than the venous system. So the venous return cannot get sufficient blood to go back to your right atrium, your heart. So the right equation here, actually, that by physics, you can really calculate. You don't need to remember the equation, but I just want to explain, because when the sympathetic innervation will cause a vasoconstriction, when it causes vasoconstriction, actually they increase the resistance as well. But the pressure during the vasoconstriction, the pressure increase is higher than the resistance increase. So that's why they can override the resistance. So that means when the sympathetic innervation will cause the stronger the venous return. Okay? So that means when the patient faint, then compensation after how your body compensates the syncope, because it will eventually increase the sympathetic innervation, increase the sympathetic activity, and increase the venous return, increase the heart rate. So your patient can go back to the normal. So that's why they say here the sympathetic innervation actually they increase the venous return. Okay? Another several mechanism here we can see that cause the pressure can go blood go back to the heart. So that's what we call a skeletal muscle pump. And this we also know because in your lower limb, because of our posture. So sometimes you stand for a long time and then you need to change your posture, change your position. Even you bend your knee or do something else. So that will be the muscle contraction and push the blood from the lower part go back to heart. And also the valve in the vein prevent the blood return to a lower position. When you open the heart, do you see the inferior vena cava? Actually, there are valve in the inferior vena cava. Do you see that during the dissection? Okay, if you have a chance, you can look at that. Even the coronary sinus opening, there's a valve, so we prevent the blood go back to the coronary sinus. Okay, so the gravity, the gravity of everything is down. So that's why the syncope especially happen when the people stand. You see the movie or the guards where they have to stand very straight for a long time. Usually, sometimes they faint. I think that the Jimmy Carter funeral, a guard just fainted, right? Because it stands too long, because the blood cannot overcome the gravity, so the blood cannot go to the brain. So basically, it's a kind of syncope. So in order to allow the pressure and to push the venous return, another pump we call breathing pump, respiratory pump. This is so-called, for example, when you breathe. When you breathe, that means your diaphragm go down, right? And your throat wall go up and anteriorly, right? So everything will increase the negative pressure of the lung. Actually, is we call intra thoracic pressure or intra pulmonary pressure. Allow the air can go in your lung. We mentioned that in the respiratory system. But by doing this, actually, when they increase and make a negative, they will reduce the atrial pressure even more. So they can bring in more blood, go back to the atrium to increase the venous return. And also when diaphragm go down, when they go down, actually increase the pressure in your abdomen. Because the inferior vena cava in your abdomen, all the way they pass through the diaphragm and go into the heart. So they will, when they increase the abdominal pressure, also they push the blood in the inferior vena cava, so they can push back to the heart. So that's what we call the pump, the respiratory pump. So we allow to increase the venous return. So when you increase the venous return, that means you increase the preload, right? And the afterload, we just mentioned, you have to overcome the pressure in the aortic arch or the pulmonary trunk, allow you to push open the semilunar valve. So something happens if you have a factor, something like hypertension, you can see the pressure getting higher. Compared to normal, maybe in a normal situation, you only need 120 to open the semilunar valve. But if the patient who has hypertension higher than, for example, 140, so your heart want to push open the semilunar valve, you need to use more than 120, maybe you have to use 140 to open the valve, allow the blood to go in here, go into the artery. So that's why the afterload will impact the stroke volume. Another, the valve damage, or called aortic stenosis. So like the valve cannot close thoroughly, so that's why the pressure cannot really pump sufficient blood into the aorta. So that's the one thing also called the stronger afterload. Another factor like hypertrophy, so many different things. So, but now you need to know what the afterload actually is the pressure. Preload is the volume. Remember? So we just say the preload, we cannot really measure how strong the vessel stretched, but we can measure how much blood into after the filling in the ventricle. So that's why we're using the preload as the refer the pressure, how strong the ventricle can contract. But the afterload is really the pressure because we can measure in the aorta, in the descending aorta, which is the pressure. So that means afterload is the pressure. Preload is the volume. So that's that kind of thing. So the contractility, we mentioned that in the first part of cardiac electrophysiology. So right here, very similar, like you learn from the skeletal muscle. But one thing here I want to mention, the sympathetic innervation. The sympathetic innervation, you remember we talked about it, the sympathetic innervation, and then using the beta receptor. The beta 1 receptor, when they binding on the beta receptor, and then trigger one enzyme we call pKa. So the pKa, phospholipase Ka. So this enzyme will trigger, what happened? Okay. Will trigger the enzyme, the receptor we call ryanodine receptor, which is the receptor expressed on the small, on the ER membrane. So this receptor will trigger calcium release. So by this mechanism, the sympathetic innervation will increase the pKa production and increase the calcium release. So that's why it can increase the contractility. Okay? So one several term right here, if the positive increase of contractility, we'll call them positive inotrope. If the reduced contractility, we call negative inotrope. So that's the reason why, because the sympathetic innervation, it can be immediately. So that's why we call them fight or flight. So it can immediately change the function, the activity of the heart, even vessel, increase the blood pressure. So they can immediately help you to deal with all situations immediately. Okay, so that's why we had, right here we call them the acute change. So that will refer to the receptor that we call them a very long-term or short-term regulation. So that's the blood supply. There's 3 different systems to monitor our blood supply, blood pressure. So one we call a high pressure baroreceptor. So in the cardiac sinus and the aortic arch. And the other we call low pressure baroreceptor. It's expressed in the atrium wall or the big vessel of the pulmonary system. So another system we call renin, angiotensin, aldosterone system, RAAS. So the 3 different systems to monitor your blood pressure. So there's high pressure here. That means you prevent your blood pressure going too high. So the mechanism we'll talk about in the next slide. But the lower pressure here in the atrium or the pulmonary trunk, usually we call a low pressure baroreceptor. They will monitor because it's the venous return. When the venous return go into the right atrium, too much blood, so your heartbeat will increase. Try to pump out the blood to away from your heart. So they don't want too much pressure in your heart. So that's why we call them low pressure. In the low pressure or high pressure baroreceptor, they all use the stretch that we call shear stretch. They respond based on the pressure change, the tension of the vessel wall. Then allow the nerve fiber can detect the signal and go back to your center, which is the vasomotor center or cardiovascular center, and do the following treatment. And for the long-term for the long-term system, for example, in the RAS system, so if the blood pressure goes down and renin secretion, so that means they detect when the blood flow through the renal artery, when they detect too low of the blood pressure, then they will secrete the renin. And so when they secrete renin and it facilitate the production of angiotensin II. So the angiotensin II is one of the vasoconstrictor, right? So they can increase the blood resistance and also increase the blood pressure. In the other way around, so if your blood pressure increase and then reduce the renin secretion, then we reduce angiotensin secretion. Okay? So one thing I want to pay attention to is so-called the band bridge reflex. The band bridge reflex is a thing, so like the venous return to the heart too much. So the stretch on the atrial wall, they will send too much blood and then will immediately, they call the sympathetic nerve innervation, activity increase, allow the increase the heart rate to pump out more the blood. So they don't want too much blood in your atrium to damage your heart. And so that means something happened, the respiratory center arrhythmia. So that's kind of thing when you increase, when you're breathing, inhalation or exhalation. We just mentioned when you inhale, the diaphragm go down. So basically, we'll increase the venous return, right? When I increase the venous return, we'll go back to like the first one we said. The atrium, they will send the stretch because the pressure, a lot of blood in the atrium, then it will increase the heart rate. But when you expiration, your diaphragm go back to normal. So then your pressure go to a normal. So you will reduce the heart rate. So we reduce the venous return. So there's three different systems. Then we will talk about it. What is the short term? What is the long term? The short term here, if you see here, the kidney and the autonomic system. So the kidney actually play a role in the long-term regulation. The long-term regulation, that means when you see right here, that's the long-term regulation. So your body will keep the normal, standard, stable blood pressure. That's the long-term regulation. So for example, what is the short term? For example, now somebody call you, you want to go out, or you want to go to the restroom, and then you need to do something, walk very fast. So that way, the short term, because your movement, you need the blood pressure change. So that's the short term. The short term regulation, they rely on the autonomic system. But here we just say the RS, not always in the long-term system. One situation, for example, now the ER had the patient pushed in, and the patient lost a lot of blood. The hemorrhage lost a lot of blood. So in that situation, the RAS system will participate in. It's a very short term to regulate the blood pressure. In that situation, the RAS system is the short-term regulation system. Okay, but in the normal situation, RAS system is a long-term blood pressure monitor system. So for this thing, so the long-term here actually rely on the hormone regulation. So that's why here we have endocrine, which is the ADH, and other peptides released from the right atrium wall. So this is based on the normal hormone control. And especially in the kidney here, a special structure we call juxtaglomerular apparatus. It's very specialized structure where secrete renin, and based on the autonomic sympathetic innervation, or based on the blood pressure change or stretch, they can cause the juxtaglomerular cell. I know you haven't learned this group cell yet, but you need just know, okay, this is part of this tissue in the kidney, but it plays a role for secreting the renin, and the renin secretion will facilitate the angiotensin II production. Okay, so from here, we talk about the short-term blood pressure regulation. So the right here, this graph here allow you, the first one, see the standard mean arterial pressure. So that's why you can see the systolic pressure and diastolic pressure, right? And you can see aortic pressure right here in notch. And but following here, just record the nerve innervation from the nerve. For example, from the carotid sinus, which is the glossopharyngeal nerve, or from the aortic arch, which is the vagus nerve. So record the signal from the nerve. And then when I see if the pressure, now the y-axis is the pressure, if the pressure getting higher, then you can see the firing action, the firing frequency getting stronger and stronger and stronger. Well, so that means pressure too high, getting higher and higher, and then the nerve send back a signal more often. So that's very urgent to tell the center pressure too high. So now the pressure receive the signal and start to processing the signal, and then decide, okay, now the pressure too high. Not only one person told me, a lot of people told me, pressure too high. Then the center will do the following work to reduce the sympathetic activity, to increase parasympathetic activity. So that's why in the center here, they trigger the sympathetic activity. If the pressure too high, then they will reduce the sympathetic activity. But they will increase the parasympathetic activity. So that's why the heart rate will go down, contractility go down. Okay, make sense? Okay, so that means this pressure is so-called high pressure baroreceptor. You can see in the carotid sinus or aortic baroreceptor in the aortic arch. So that means during this situation, there's a reflex we call baroreceptor reflex or baroreflex. So this reflex actually sometimes going up, sometimes going down, based on your mean arterial pressure. If the arterial pressure goes down, they will increase the sympathetic activity. If the pressure goes up, they will reduce the sympathetic activity. So that's the so-called the baroreceptor reflex. Based on your autonomic nerve innervation regulation, and to reach the goal to do the vasoconstriction or increase the heart rate. Okay? Okay, cool. So now, the baroreceptor here, actually, if you look at the flow chart here, you see here, if the mean arterial pressure go up, then we'll call the center through the glossopharyngeal nerve or vagus nerve. When they do this, then they will send a signal to reduce the sympathetic activity. In your new version, you do have this in content, okay? Don't worry about that. I will keep you updated. So right here, if you look at here, and the other side, if you have a try to reduce the mean arterial pressure, then we will increase the parasympathetic activity. Okay? I think that's easy to understand. So using the autonomic nerve innervation, the regulation. And at the beginning here, I left it blank, allow you to see and write down your note. But in the end, I think okay, I can help you to summarize something. So that's why I wrote the content here and highlight something important for what is the activity for the sympathetic innervation. Actually, increase heart rate, increase contractility, and during the heart pressure too high, and then we can reduce the sympathetic activity. In the other way around. Okay. Look at it, the structure, the instruction here. So, for the autonomic system, we only mentioned the blood pressure, but if you look at the right side here, actually the parasympathetic not only innervated the heart here, but also some sacrum region. So in the productive system, the urinary system, the parasympathetic play an important, very, very important role for their function. But it seems like in the heart, in the cardiovascular system here, the parasympathetic only play a role to reduce the heart rate. Okay. So that's something you need to understand here. So that's the flow, the summary, the flow chart. I think you can understand the parasympathetic to the heart rate and parasympathetic to the heart rate and the vein and also the arterial. Okay. And then eventually will reduce the blood pressure or increase the blood pressure. Okay, are we good with this? Okay, we don't need to spend time to explain this. And the other thing is for the RAS system. And so here again, initially it's blank. So, but I think I can help you to have some notes here and allow you to understand better. And because in this system, it only detects the low blood pressure. And then when it detects low blood pressure and it trigger the glomerular cell will secrete renin. When they secrete the renin, and then they will, like, when they go here and the liver will produce the angiotensinogen, it's a precursor. And then the renin will convert to the angiotensin 1. And then angiotensin 2 need to another enzyme to convert to the angiotensin 2. Where is that? We mentioned in the endothelial cell, there's the enzyme ACE. Remember that? The converting enzyme, so the angiotensin 1 will become angiotensin 2. Then angiotensin 2 will become the vasoconstrictor to make the radius smaller. Okay? Increase the resistance. And also the angiotensin 2, but also trigger the posterior lobe of pituitary gland to secrete ADH, which is vasopressin. The ADH usually mainly work in the kidney, but in order to control the blood pressure, so they also work on the blood vessel as well. And also the same thing in the hypothalamus also will send a signal to your brain and know I'm thirsty, I need to drink water. So that's why the hypothalamus will respond. Okay, you need to drink water. So sometimes you low blood pressure, you want to drink water. That's the reason why, because your body tells you, I want to increase blood pressure. Okay, so again, so this system will sense the blood pressure from the kidney. When the blood goes into the kidney, then they will sense either the low blood pressure or the low sodium concentration. We don't mention the sodium right here because I don't want to confuse you. And in the renal system, we'll mention this again. Now we will add in the sodium because it's a lot of convoluted tubule in the kidney. So we'll add in the concentration of sodium and trigger the renin secretion. But right here, you just only need to know the renin secreted from the JG cell, which is just a glomerular cell. And following here, the trigger ADH or the aldosterone right here. Actually, aldosterone is for the sodium reabsorption, and potassium secretion is important in the kidney. But even because we mentioned this system, we need to know because angiotensin 2 will trigger adrenal gland to produce aldosterone. But this one will work on the kidney. Okay? Overall, this is the long-term system to regulate your blood pressure in the long term. Okay? But when the emergency came, you need this system will jump in to regulate the blood pressure. Okay? Okay, syncope. So the syncope here, actually you look at here, we said the venous return is the prominent, is very important factor for the stroke volume. If you don't have a sufficient venous return, your stroke volume very low. If the stroke volume very low, cardiac output very low. And the cardiac output very low, so your brain will receive insufficient blood supply. So that's why I call it unconscious. So right here, if the syncope happens, for example, the people who stand too long and the blood was in so-called pooling in your lower part of the body, then they will, if don't have a sufficient innervation, activation, so the blood will be in the venous reservoir, so no sufficient venous return. In that situation, your sympathetic will activate it because you want to push more blood go up to your heart. But just because when they do this, it will increase the heart rate. When they increase the heart rate, but the venous return haven't come back yet. So there's very little heart, very little blood go into your brain. So that's why in this situation, if the patient has the pain or anxiety, there will be like a double sympathetic activity in addition to some impact from the heart, from the blood pressure. So that means the double sympathetic activity. So the heart rate is very, very fast, and the heart contract very strong. But you don't have sufficient blood. So that's why your brain cannot get sufficient blood. So the patient will faint, lose consciousness. But at the same time, your body, like we mentioned, the short-term receptor, the baroreceptor, which is in your cardiac sinus, in your aortic baroreceptor, the send a signal. Now it's because the heart rate too strong, contracted too strong. But send that signal to your center, and the center say, okay, now I need to get in lower heart rate, lower contractility. But when I do this, the parasympathetic overreaction, just because they're too strong of the sympathetic, they want to reduce the sympathetic activity. So the parasympathetic activity overreact. When they overreact, they will reduce the heart rate. The parasympathetic has the ability to reduce the heart rate to 0, no heartbeat, if the too strong parasympathetic activity. So that's why your low venous return and your parasympathetic overreaction. So the patient who had bradycardia, so very slow heartbeat, very slow blood pressure, so that's called hypotension. So at the end, then it cause the patient lose unconsciousness. So that whole thing here we call it syncope. But it's the vasovagal, just because the vascular system and the vagus nerve are participated. They participated in this whole thing. So that's why we call vasovagal syncope. For the one-turn syncope, that means faint or unconsciousness. Okay? So if the patient has a syncope, how do they recover? So the same thing, because when the heartbeat go down and the contractility go down, so now your center will receive another information, say, hey, the heart rate too low. We need to go higher or stronger contractility. So they will increase the sympathetic activity. So right here, you see here, the syncope, and then the input just want to tell the center, oh, now the pressure too low, the heart rate is too low. So that's why they want to reduce the efferent nerve activity. When they reduce, that means increase the sympathetic activity. Okay? So when they increase sympathetic activity, now the whole system, the cardiovascular system, keep working, start to work. And then they will increase the contractility, increase heart rate. Then we will eventually increase the arterial blood pressure. But again, very important, venous return have to go back to normal. So that means the sympathetic innervation not only work on the arterial, but also work on the venous system to contract the venous system to move more blood go back to the heart. So if in a minor situation, if you can move, probably you can move your body, move your leg, allow the pump, the skeletal muscle pump to pump the blood. Or even you can do the deep breathing. Allow you increase the space of the thoracic cavity to increase the pressure in the abdomen and then bring more venous return back to your heart to increase the preload. then they work together, then the patient will restore back to normal. Okay? So that's what we call the compensation of syncope. That's one, the take-home message here. Read it and understand that part and complete the quiz. And remember, we have a quiz. You have a first quiz after the lecture, which is electrophysiology. It will do on Friday morning. So another will be this quiz after the lecture today. We'll open at 7 something, but we'll close on Friday morning. So we have 2 quiz, and to understand the part and earn your credit. Okay, so I know it's very short, but you have a Q&A on Friday and then the exam on Monday, so we have to do very quick. So last one, I will show you this one, the last slide. So how do you calculate the mean arterial pressure? So based on here, you have 75 heartbeat, and then you have pressure, which one is the systolic pressure? 120, right? Diastolic pressure? 80, right? And what is the pulse pressure? Pulse pressure. What is pulse pressure? The pulse pressure means the difference between systolic pressure and diastolic pressure, right? We call pulse pressure. So that means when you want to calculate the mean arterial pressure, that means you need to do this solution. You need to have a diastolic pressure, right? So which is 80, right? And the pulse pressure is the difference between the systolic pressure and the diastolic pressure, which is 40. 120 minus 80 is 40. And then 1/3, you calculate 1/3. And then what is the number? What is the mean arterial pressure? B, right? Okay, that's B. So you can calculate the mean arterial pressure. It's 93. Okay? So back to this is a slide from the first part. So you have a mean arterial and then a pulse pressure right here, and based on a different situation. So remember, the pulse pressure is the force. The force allowed to evaluate how strong of the arterial wall, which is elasticity. And the mean arterial pressure means its overall perfusion rate. So your organ, your body, your cell, how much blood you can get is the mean arterial pressure. So that's the difference between them. Yes?
What are the different curves in this figure?
What curve? The mean arterial pressure?
Yeah, like the purple curve, the blue,
The curve here?
yeah.
So that's just the arterial pressure. You see the Uyghur diagram? You see the aortic pressure?
Yeah.
So that's why you can see here the systolic pressure and the diastolic pressure. Okay?
So this is
Okay. So I need to end right here. Okay, any question? Okay.
On the side where we're talking about the sympathetic stimulation with the myosin light chain phosphatase, are you saying that it activates or that it inhibits that enzyme? First slide, like the activation of nitric oxide.
You mean the slide here?
Number should be 28. So at the end, when we have the CGMP, are we saying that myosin light chain phosphatase is inhibited or activated?
MLCP? So let's reduce the activity of the enzyme. When they reduce the activity of the enzyme, we will reduce the binding ability for the myosin and the actin.
So I thought we would increase the activity of the phosphatase.
No, they reduce. So probably reduce the kinase activity.
Right.
Yeah. Anything? Okay. So any question we can prepare on Friday. We'll still have time. Okay. Thank you. Sorry.
Thank you, Dr. Huang.
Hello. No, because they had an event and right here, so they won't end at around 40, 50, 140, 150.
Okay,
So
yeah.
there's a kind of delay. So sorry about that. What's that? I don't see it.
This one or the other one? Oh, you have your...
Yeah, we have one here. Yeah, I think that this one is good.
Yeah, this one is... So physiology is very difficult.
Physiology.
Yeah.
Yeah, it's complicated for them to understand. So many things they make not just simple topic. Sometimes you need to know here and there and allow to understand everything. So it is
So
challenging.
you can do anatomy and physiology, everything. Can I remove
Oh,
it?
yeah. Sorry about that.
Oh, no problem. So right, hello, how are you? So you must be tired, right? So we only have one session to review, so you won't take long, okay? So let's get started. So what do you have here? So can you name the blood vessel type? So for the blood vessel type, first determine whether it's an artery or a vein. Arteries are usually round, strong, firm, with the thickest, the middle muscular layer, right? So which is tunica media. And while veins show like elongated, large, irregular shape with the thickest, the adventitial layer. So is this artery or vein? Right? So it's not completely round, but right, we have a thick middle muscular layer. Okay, so this one is artery. So specifically, so maybe we can discuss this later. So let's quickly check the layer. So we know from the lumen side we have tunica intima, right? Lining endothelium, thick connective tissue, thin connective tissue. But at this magnification, we usually cannot see clearly the tunica intima. Okay. Then we have internal elastic lamina, so which is a continuous elastic tissue, can mark the boundary between the intima and the media. Okay, so tunica media is a middle muscular layer, contains multiple layers of smooth muscle cells. And then we have external elastic lamina, can mark the boundary between the media and adventitia. Also usually it's difficult to see the external elastic lamina. And outer layers we have adventitia, which contains collagen fibers, like blood vessels and nerves. Okay, so can you name the specifically like blood vessel type? So we have three types of arteries, right? Is this one elastic or muscular? Yeah, this one is muscular artery, right? So how do you know? Right, so we have distinct the internal elastic lamina, right? So if you can see prominent internal elastic lamina, so this one should be the the muscular artery. The major cell type in the layer A and B. So A is the smooth muscle layer, right? So the major cell type should be smooth muscle cells. And B is connective tissue. So what is the major cell type in the connective tissue? Yeah, fibroblast, right? So B is fibroblast, named the linear structure. So this one is external elastic lamina. Okay, so name the blood vessel type. So when you look at the wall, so we have many these wavy lines, right? So these are elastic laminae, right? So what is the artery type dominated by elastic materials? Right, so this one should be elastic artery. Okay, so they receive like high pressured blood from the heart. So these elastic fibers can give you cushion or like flexibility. They can stretch out. Okay. So let's quickly check the difference between the muscular and elastic arteries. For the muscular artery, so we have one usually prominent internal elastic lamina, right? So you can see like here. Also, for example, we saw, right? So this one is very distinct, right, near the lumen. So we have internal elastic lamina. Okay, for the elastic arteries, we have many, right? Many elastic the laminae in the wall. Okay, so this diagram shows like these blue lines represent the elastic materials. So you can see basically the basic components are the same, right? So you still have 3 layers, middle, right? So the smooth muscle layer, but just elastic arteries have more elastic materials in the wall. Okay, so name the blood vessel type. Okay, so several of you got confused with the size of arterioles and venules. So these are arterioles, right? So by definition, arterioles have a diameter of less than 0.5 millimeter and containing 1 to 3 layers of smooth muscle cells. But it's difficult to count the smooth muscle layer or measure the diameter. So instead, so you may count the total number of nuclei. So I told you less than 10, right? So for example, this one is like 1, 2, 3, 4, 5, 6, 7, right? 1, 2, 3, 4, 5, 7, right? So try to remember the size of arterioles. Yes?
I didn't mean to interrupt, but I was just asking for clarification. On the last slide, it said tunica externa. Is that the same as the adventitia?
Oh, yes, yes, yeah. Okay. Okay. All right. Okay, so which type of blood vessel is shown in this image? So what do you have here? It's artery or vein? Yes, right. So we have a thick middle muscular layer. Yeah, this one is not good image, but so I brought up this. So what is the dark staining layer at the arrow? Yes, this one is internal elastic lamina, right? So depending on the staining, sometimes so it can show like a pink, white, or black. Okay, so if you have like any obvious like this, the thick line close to lumen, so this one is internal elastic lamina, and those should be this type of artery should be muscular artery, right? Okay, so name the blood vessel type. So now we have like large, elongated, irregular shape, now. So this one should be a vein, right? So what is the thickest layer in a vein? Right, so the adventitia. The thickest layer for the artery should be tunica media, and the thickest layer in the vein should be tunica adventitia. Okay, so name of the layer at the arrow. Please do not get confused with the tunica intima. At this magnification, we cannot barely see the tunica intima, right? So we saw it's very thin, tiny layer. So this one is tunica media. Okay, so middle muscular layer, and from here to here is tunica adventitia, right? So you can see the tunica adventitia maybe 1, 2, 3, 4, 4 times, like larger than tunica media. Okay. Okay. So name the common structure by the arrow. Okay, so before discussing this, so what type of blood vessel do we have here? So when you look at the wall, so we have many these wavy lines, right? Yeah, so this one should be the elastic artery. And so how about this one? Right, so it's not completely round, it's very small. So when you count the nuclei, maybe 1, 2, 3, 4, like 1, 2, 3, 4, 5. So these are good examples of a venule, okay? And this could be an arteriole. We have another venule here. Okay, so for the arterioles and venule, we are looking at very tiny, very small blood vessel type. Okay, so the common structure is so like blood vessels. So inside the blood vessels, right? They are called the basal basarum, right? So also blood vessel needs supply of nutrition and oxygen. So they are usually can be found easily in the adventitia of large the blood vessels. Okay, so all these okay are basal basarum. Okay. Okay, so name the blood vessel type. Okay, so this one should be an arteriole, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Kind of bigger side. Could be like a small the artery. This one is the venule, right? So elongated, the large. So usually like the arterioles and venules, they go together, okay? So this is, okay, so venule. So what type of lining epithelium do you have? Yes?
Does the counting the nuclei rule count for the venules as well?
Oh yes. So this could be the like bigger site. So I would say it's more than 10, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it's okay for small vein, or it's okay also for the venule. Okay. So for the lining epithelium, so we only have one type of lining epithelium, right, in the whole circulatory system. So what is it? Yes, simple squamous, right? Single layer of flat cells. You can see these endothelial cells, right? So single layer of flat cells. Okay, so for the comparison of an artery and vein, so histologically, right, they are very similar. So the layers, components, but arteries are usually round, firm, veins, large, elongated, irregular shape. Okay, and the thickest layer in the artery should be tunica media, the middle layer, and the thickest layer for vein should be the tunica adventitia. Okay, so when you look at these images, also this image, for the artery, okay, so we have the intima media is from here to here, and adventitia is here to here. And for the vein, okay, so we have intima, the media, and adventitia is much larger, right? And also the veins have valves. So it's going to be another big difference. They any folds of the tunica intima, like they can prevent backflow of blood. So they are the valves. Only the veins have the valves. Okay, so this is a heart. Identify the layer at zero. So this one should be easy, right? So like the blood vessels, also heart have 3 layers, right? They are histologically very consistent to those we saw in the blood vessels. So for the heart, so first try to determine which direction is inside and which direction is outside. Okay, so it's usually the inside is clean and sharp boundary, and for the outside, because we have connective tissue, right? So usually the dirty and unorganized. Okay, so you can also see some large blood vessels. So here is the inside, so here is outside. Okay, so from the inside we have the endocardium, the myocardium, and epicardium, right? So endocardium, myocardium is like middle muscular layers. So epicardium is connective tissue. Okay, so the layer should be on epicardium. Okay. So name the entire organ. So this is one of the popular the questions in the histology. Okay, so when you look at this image, so when you see these lines in the muscle cells, so you should be able to tell. So you are looking at the heart. Okay, so what are these lines? Yes, it's intercalated disc, right? So they run like perpendicular to the direction of the smooth muscles. Okay, so they the 3 components make the intercalated disc. Okay, so right, so fascia adherens, desmosome, and the gap junctions. So fascia adherens is like ribbon-like structures that can link the cell membrane by actin filaments. Desmosomes, spot-like structures linking by intermediate filaments. Gap junctions and small pore. Okay, so they can passage of ion. They can spread the action potentials across the cardiac muscle cells. Okay. All right, I think. Oh yes, I have one more. Okay, so name the blood vessel type. So it should be easy, right? Yeah, so this one is capillary, right? So by definition, capillaries have like a tiny tube. Diameter is less than 10. So we know the IVC size is about 8, right? So single IVC can barely fit in capillaries. So they can pass through in a capillaries in single profile. Okay. All right. I think that's all for yes. So, do you have any questions? All right. So histology, cardio histology should be straightforward. So, okay. Yes.
Can you repeat what the function of the desmosome is?
Oh, I'm sorry.
The function of the desmosome?
Oh, so desmosome. So basically, they connect the cell membrane. So it's just like a spot-like structures, but connected by intermediate filaments. So they just link the cell membrane. Okay. All right. So thank you very much and good luck. Yeah. Okay, thank you.
left.
In an hour and a half for drilling, yeah. Or not drilling.
Are you serious? Where are you going? You said yes. You said just why? For real? For real? Why?
Glasses?
No, I'm good. Thank you. I drank so much of it. No, I'm good. Thank you.
Hey. You have dinner?
Yeah.
Yeah.
Why not? We'll sell law. Better than the radius one for. Oh, wait, there's more. The radius one's crazy. I know, the radius one. I really think the engineer could do that.
It's just always like the decreasing or increasing by the power of whatever.
I think it'll be multiple choice. Oh, decrease, so what would happen to resistance? You go to Lex? Go X. Go X. Go X.
Hi, tomorrow.
Hi, Travis. And then this one, number one, he said. Okay, bye, Travis.
Like, okay.
I just said hi.
And I said hi, but you didn't acknowledge it.
I did. She wanted to start a conversation.
Yeah. Hello, Eric. I was so excited. I went, hi, Travis.
Let's talk about. He said.
Bye, Travis.
Bye.
No, you're good.
The senior applies to one. You want to go to? They have to be less than 10. Yeah.
¿Me quieres comprar la computadora? Mandé. ¿Me quieres comprar la computadora?
Between an artery and a vein, but not a venular and a vein.
There better not be.
Okay, that's what I was asking you. I said there was between a venular and a vein.
No, there
You said
better
no.
not be. Scared you, Chad.
Okay. I thought you were saying I'm scared of you because I'm so down the line.
No, you're not. You're probably sort of. Nothing like this. I'm just going based.
Arteries are around. I mean, I'm just
Yeah.
and then veins are kind of longer than a regular.
Just epicardium.
Okay.
Why? No, just actually, you know, I told you. I'm telling you. Thomas Maxey. Yeah. It's Becky gave nothing. Yeah. And you equated this. Oh, no, this is oh, hell. What's your favorite? This one I put that is heart and provides for cardiac and then for whatever was the linear structure, that's in your big this. And whatever the components.
It's like a critical, you know, slide now,
Gap junctions. Gap junctions fascia adherence. Fascia adherence is what actually ligand, what they say ligand to the muscle.
pero la sensible ya, right?
Yeah. He just said here ligands. The gap junction is those poles that actually.
Yeah, no, it's
This last one's put continuous capital.
oh yeah.
Continuous capital. Yeah, these are like Thank you so much. It'll actually be short.
Yo es que sí, igual. I just talked about the
Yeah,
I will do that. But yeah, take it up.
Everyone's gonna be there. It's gonna be like a party.
Right short too. That's not a lot. I think I agree with that. But it's good mechanical stuff though, even when they like chuck it themselves.
Oh, that's what I think later. I'll be like,
And
this shit sucks.
just knowing that they really fucking like slap it down.
They don't slam it. They said they don't slam it. They just.
I saw the big ass fucking like when I got my back, I saw like the big fucking.
Well, they show you like yesterday during like your huddle.
Yeah,
How they do it.
I had pinpoints on mine, right? When I turned it in and when I got it back, I had like some fucking fat craters. And I practiced doing that, and the way I replicated on my own was like that.
They told me
I was like
to
gentle, like tap, like fucking.
They told me to stop doing that. They said that they want you to try it out first with the things. They want you to tighten and then just drag it. Drag it around. Because they did it for cookie. They're like, please ask your facilitator to show you how we're gonna be grading. And then when it's for context is when they go. And so yeah.
What should we present it?
I think it's really wise. I went for like 30 minutes. We had like the pre-huddle thing, and then we had her as our facilitator for the thing, and then we played out in like 40. By the time I saw her, we came back at 45.
You guys have post huddle. That's why. Post huddle. That's what I.
Yeah, it takes a long time. It was like 4, and it's like everyone get your waist. I'm like, damn, I'm ready to flex it.
Yeah. Okay. Because I heard her go like, okay guys, post huddle, and I was like, yeah.
And then you ask them anything and pass for 30 minutes, like, oh, I gotta go. I don't get paid enough. I'm like, damn. Yeah.
But I did think of it, so I haven't really too much of our resume anytime. I have, I forgot to subscribe.
return half of the money, you're fine. Some of the stuff that I see sometimes is like, they take more of the money that they like, you know, and then like they have to repay only certain amount. Like I'm like, damn, you know, I'll come with the crime too, you know. And they don't have offices or anything. Yeah, but yeah, we walk in to scam and they're like, nah, everyone that looks like him, scam, so guilty.
Jail.
15 years.
Not everything. Oh, guys.
Oh, see, yeah. The new one came out? I haven't seen the new one. I saw the old one. Some woman. The YouTubers. Oh, she works there?
Well, she's gonna work. She's going out. There's no board, you know, like, there's a big board with a bunch of
It's like a whole ass one.
and it doesn't. Pero the awareness of it is like this.
I heard that in
The hospital's bad, actually.
in Berkeley they found out. So sad. They're like, oh, they're finding so many people.
Some crazy ass boyfriend and then shit, that's crazy. Took her on the trip and it's like, you come back home and it's like, you know where she, you know? Like the parents too, like I remember watching that, like the first one.
Yeah.
The parents were like, you know, not covering up, but like, I feel like they had to know.
Oh, yeah, there's like years ago. There's like here's the cash on the place and there's like, hey, go top.
And why?
Some of the credit, I can get credit.
They were like, yeah, le dicen ahí todo lo que
Fucking
pasa.
breaking doors down, fucking burning the house. I mean, basically that.
Like, what is it like? Like, that has to be in here.
Killer? Like,
It's
that's
like,
something?
why is it all?
I didn't read about like, it could be like anything. But that's why I feel like it's all how you grew up. It could be both. And there's like also the one series about like the guy who killed all his like family. Some white guy, I don't know where, he was in a house and they just shot him. Like there was one I watched where like, yeah, he like the wife had the kids, you know, that's like one of those like, well, I don't have the kids stuff and shit, you know?
Oh, I understand that. Yeah. Yeah.
And like he killed the mom and then he went to go pick up the kids at practice or shit like that. He's like, yeah.
Yeah, it was like everybody like super like fit.
Yeah. And there's one about it, I think it's like oh like bad doctor or something like that. He had like a wife like here and a wife like in Spain. And like he would work in both places. So when he would travel here, he would hang out with the wife here. And then he'd be like, yeah, I'm from Spain, like I'm gonna take you to my house. And like he just kept like, you know, playing that. Catfish. And then like she went and like walked into the fucking house and like saw like there was a woman and a kid. But she didn't say anything to the woman, but then like later on she did like, you know, like husband has, you know. I was like, damn.
And it's crazy, like that's not already to watch anything except on TV. And it's super quick, so a show can take
Yeah.
2 months.
Yeah.
Because it's like we're eating it and we're done like in 15 minutes. Alright, we'll pick this up tomorrow. Or on the weekend it's like we'll eat breakfast and then like lunch and then dinner. So it's like
I think I'm gonna
watch
watch
it every episode at least. So it's just like
That's not
I
right.
don't know how to do this.
it's a sad life.
Those are like the OJ Simpson. I watched it the other day.
Oh, it's on one.
That's like the OJ Simpson. I don't know how there's like,
A little bit of it.
this, yeah, there's no shit. I'm like,
Oh, I know
wow.
about that.
That's crazy. That's the first one that came up. Yeah, you should really know to go.
It's que he was lucky because there was a cop that was like really successful. And he was like working. So like, what the lawyers went after was about the cop, not even about like the actual crime scene. So they're saying like, well, that, you know, we can't trust anything that's there because that cop is racist and he has so many. He had like a lawsuit against the like LA department. He's like, I want to retire because of how racist I am, basically. And you gotta pay for everything. Yeah, like these people pulled it out. I'm like, damn. And he was getting interviewed and he's like, yeah, that was my past. He's like, everyone hated me because of was sitting in the first meet. She was saying like my name like, she said like baffled it, and like she didn't even say like after I said right. I was like, she didn't ask like I was like, oh you didn't say that right. Like I spoke out loud, and then everyone like looked at me. It was like during the free bottle, and she's like, so how do I say yellow because like you know? And she's like, oh I might not be able to say that. I'm like, oh my god. And then she said it. Yeah, I was like, bro.
It's a good old try.
Yeah, la persona. Tú ves esa señora cuando oh, they like she's like, oh, I forgot my pencil.
So I intentionally not like I was like
Go up to her.
Oh, you're trying to be funny. Show her that you're a safe space.
I'm safe space, but I was like, no, that's not safe space.
I guess you say.
Oh, I see.
Oh, la tela blanca. Oh, yeah. I only went in there once because I think they made me take shots that I didn't need. Because like I took them and like I had well you know how first you get the titers on and they're like, oh you need these shots. So I was trying the titers and they're like, give me these shots to look for the school. So I went to go take them and I finished like in January like all the doses. And then I was like, can I get a paper so in case like they ask for go to call my shots, and I went in there and they're like, oh you're good to go. Like I was like, no, because I mean she didn't ask me tighter. I asked Robin first, and then she sent me to the other girl, Jennifer. Yeah. At first I was like I didn't notice que tenía como por like no la otra Jennifer. They're in the same office. But you know who got para allá and like it was like she was looking at her computer. I was like standing right there, and like reminds that she was like looking at like, the computer, but then she was also looking at me like over there. So I was like, I don't know if she's looking at me or the computer. Y pues ya le seguí platicando, so she's like, oh you're good. So I was like, I was so tired today. I was like, so I didn't need these shots and really take them, but I was like, whatever.
When I'm in those situations, I kind of just look down.
You just have to choose one.
Yeah. Well, I mean, I was just like,
Make a choice.
Make a choice.
I mean, you do.
I always look away. What do you do? You look
I just look at her face, not like at her eyes. I like look at her like eyebrows or something, you know?
So right now, if I'm looking at you, I'm looking at your nose. Does it look like I'm looking at your nose? Or
No, it just looks like you're looking straight.
like I'm looking at you?
Yeah. But if you're close, I think you can tell what you're looking at.
Alright, so
But if you're farther like that, yeah. Y su foto cuando